For today's lesson, we're going to look at the axial skeleton, and specifically the vertebral column component of the axial skeleton. So the vertebral column, you'll notice in your books, you've got a picture that looks like this one. And in this picture, you're asked to highlight and then describe and write down the names of the sections of the vertebral column and also how many vertebrae they are. In this top part here, we've got the cervical vertebrae. There's 7 cervical vertebrae. That's that top part of your neck, this section up here. Then we've got our middle part of our back, which is our thoracic vertebrae, and there's 12 labelled T1 to T12. That's 12 thoracic vertebrae. There's 5 lumbar vertebrae. There's 5 sacrum in your sacrum, and then 4 in your coccyx. The difference between the sacrum and the coccyx is these ones are all fused together. So you'll notice here, it almost looks like one bone in your picture. If you have a look there, there's like one bone. There's like 9 fused together vertebrae. So 5 in the sacrum and 4 in the coccyx. Although these ones up here, they're all moving freely. Now, why do you think it's shaped like an S like that? Why do you think they're just not stacked on top of each other? They're shaped like that because of both movement and also like a shock absorber. It's like a spring. So they're shaped like that so that there's a little bit of movement and shock, and also when we look at the way we move, like bending forward through our back and leaning back and forward, this movement pattern helps with that as well. Now there's one easy way to remember the amount within this section, and we call it the pensioner's meal plan. So there's 7 cervical vertebrae, we have breakfast at 7. There's 12 thoracic vertebrae, we have lunch at 12. There's 5 lumbar vertebrae, and this is the part like that doesn't really make sense because 5 who's eating dinner at 5, a pensioner is eating dinner at 5, that's why it's called the pensioner's meal plan. And then we've got 9 through the sacrum and coccyx, and the 9 represents the 9 fused bones, and we might have supper at 9. You probably want supper at 9 because if you're eating dinner at 5, you're starving by the time you get to bed. So 7, 12, 5 and 9, the pensioner's meal plan. So do you think that we're born like this? Do you think we're born with this natural kind of S-shaped curve? Or do you think that maybe we develop it? Yeah, that's right, we develop it. So we're not born like this, we develop it over a series of early movements that lead to this. So right now, this next activity is we're going to have a look at what happens when we develop this curve, throughout birth into our, infancy, and how it might change during this time. So at birth, we are born with one primary curve. So if I were to draw like a stick picture of this, it would look something like this. Here, that end, so this is us when we're born. We've got this one primary curve, and it's the curve of the thoracic region. And then as we develop the ability to lift our head. Obviously, we're coming out into the world, we want to see what's going on. So we have this change in curve that allows us to lift our head. Right, so to put this in context, person sort of facing down that way. So we've got here this one primary curve in the thoracic region at birth. Then we've developed the ability to lift our head, so we've got that cervical curve coming through. And then we develop the ability to sit and stand. So we've got the lumbar curve also coming through. So it looks like that. Yeah, and here's our person. All right, so we've developed from birth to up through our infants and to where developing the ability to stand and walk around. So the curves are responding to the way we move. First lifting our head, then sitting and standing and walking around. Now, if I were to continue drawing this picture, we would still see the sacrum and coccyx looking something like that, still curved in that first primary curve. So let's just flip this up this way. This is more like what we look like now. It's obviously not to scale. This person's got mini legs and mini arms, doesn't even have hands. But you can see that curve here of the sacrum and coccyx is still in that original position. So if I were to ask you, why do you think it's still in that original position? Think about it now. Why do you think this might be in the original position? A number of ways you could answer this. Firstly, people often say, it's like that, so you can sit, and yes, it does provide a bit of protection because you're thinking about it sort of protecting some organs down, sort of around where your bum is. But another way of thinking about it is your actual legs connect above where the sacrum and coccyx are coming down, and they're all fused together. So the sacrum and coccyx, when you think about it, they're still in that initial curve. In other words, because your legs are attaching like at the top of the sacrum, there's no real movement pressure placed on the sacrum and coccyx in order for this curve to actually change. So it's like, why is it curved like that? It's like, why wouldn't it be curved like that? It was always curved like that, and there's no movement placed on it in order to change. So anyway, that describes the curves through the cervical, thoracic, and lumbar, and then we see the sacrum and coccyx. And I will note also that lack of movement is also why they become fused together. Typically when we see bones that are in real close proximity to each other and there's no movement, they will become fused. Just think about it when you break your arm. You know, you break your arm, they put it in a cast, they put the two bones in close together, there's no movement, it fuses back together. So that's much like the sacrum and coccyx works there. So that's what happens when we're looking like it's all normal and everything's developed as it should develop. But it doesn't always develop that way. Sometimes we've got abnormal spinal curves. Now the first abnormal spinal curve we'll talk about is scoliosis. Now scoliosis is referred to as an abnormal lateral spinal curve. So lateral meaning side on. This one's very straight up and down. If there was an abnormal lateral curve, it'd be sort of swinging out sideways in some way and then possibly coming back. You might see like one shoulder sort of high. You might see one shoulder higher than the other, or you might see one leg longer than the other, but it's going to be an S shape through predominantly the thoracic region. That's scoliosis. Now you've got kyphosis. Now kyphosis, it's nicknamed hunchback. It's an increased curvature through the thoracic region. So this area here of the thoracic region, it's already curving that way. Imagine if that was increasing, you would look like hunchbacked in style. So I don't want to bend him over, but you would see this increase through the thoracic region, and of course you're still sort of facing forward, so you've got curve and then facing up. So you look like a hunchback. And then finally, we've got lordosis. Lordosis is an increased curvature of the lumbar region. So increased curvature of the lumbar, we know it's already curving that way. So if you've got an increased curve through this area, you would see the stomach perhaps sticking out and bum perhaps sticking out. So the curve through here is increased. So three common curves that are abnormal curves. So scoliosis, sort of a lateral curve through the thoracic region. Kyphosis, you've got an increased curvature of the thoracic region, and lordosis, an increased curvature of the lumbar region. So I'm going to put on the screen, right? That's just a normal sort of setting. I'm going to put on the screen some examples of abnormal spinal curves, and I want you to, as fast as you can, tell me what it is. Okay, so example number one, what is that? What's that? That's a horse. But it's a horse with lordosis, so stomach sticking out, so ass sticking out. What's that? It's a bit dark, but it is lordosis again. What's that? Kyphosis. What's that? Scoliosis. Now, the examples I put up here, they're extreme examples. So the question we ask ourselves is, can you develop these? Are you born with these? Like, what's the difference? The answer is both. You can be born with them, in these extreme cases, these largely are birth defects. And in other examples, you can develop them by different types of activity. So if you think about the first one, scoliosis, and this one here is again is an extreme case, but how might you develop scoliosis? You're looking at things like, I just want everyone in their head just thinking, how might I get scoliosis? And you should be thinking something with some kind of asymmetries. We see this really common in things like sports, like say swimming where you're breathing one side, or paddling when you're paddling on one side of the boat. We might also see, there's examples where women with extremely heavy handbags, Mary Poppins style handbags. They're just carrying it on one shoulder, and they've essentially developed some scoliosis. Kids carrying their school bags home from school always on one side can develop this. In those types of circumstances, if it hasn't gone too far and there's sort of degeneration occurring, the opposite movements could bring this back into alignment. If we think about things like kyphosis, right? So that hunchback, kyphosis, how might you develop kyphosis, right? Go back to the kyphosis example. Again, extreme case here. This is not something we typically, see, someone develop. This is more like birth defect style. Kyphosis is things like postural, sitting too long, maybe at a desk, really bad posture. Really common in people with like scoliosis. Sorry, not scoliosis. People come with like osteoporosis, degenerative bone type conditions that leads to this kyphosis type condition. And then you got things like lordosis, right? Lordosis is a really common one. You can develop lordosis, really common in pregnant women, where they're carrying a heavy load up front, dragging their lumbar spine into that lordosis type condition. The guys, you're not safe either. Things like those beer bellies, right? Drinking, smashing down too many of the beers, developing lordosis over a period of time. So anywhere where you're increasing that weight up front, you're at greater risk of developing that lordosis type condition. So in this next example, what I want you to do is just using a stick diagram, have a go at drawing what you think each of these conditions would look like using a stick diagram, and we're going to go through these examples. So if we draw a picture of what scoliosis, kyphosis and lordosis look like, we're going to see three very different pictures, and I'll draw them in a stick diagram exaggerated form for us. So scoliosis we define as a lateral curvature predominantly through that thoracic vertebral column, which means when you draw it, you really got to draw this picture front on. So we draw a person, I'll just draw his head like this, there you go, there's our person. We're going to see a curve that's kind of like, it's pretty exaggerated, but you get the idea. There's our arms, legs. We're going to see the sort of lateral curve through that thoracic region. When we draw kyphosis, in order to see an exaggerated thoracic curve, we'd need to look at this side on. So we might see something that looks like this. There's our person side on in this particular picture. He's got this big hunchback, again not to scale, mini arms, mini dinosaur T-Rex arms. We see this exaggerated curvature through the thoracic region, and of course they're still trying to look up so they can see where they're going, so you see that sort of neck tilting to go back up that way. In lordosis, often referred to as swayback, you see that sort of increased curve through the lumbar region. So let's just draw this person, might look something like this. Right, just to put this in a bit of context, let's say he's not smiling, he's frowning a little bit because he's not happy with his. So we've got the stomach sticking out, that would be like the belly button there, we'll put the ghetto booty on there. So we see this increased curve through this lumbar area with the belly sticking out and the sort of arse sticking out there to compensate for that motion. So increased curvature through that lumbar region. So next we're going to look at the bony thorax. So bony thorax is included, it means all your ribs and your sternum, which they're connecting to at the front. So also, part of that axial skeleton. So bony thorax component. So when we look at our ribs, there's 12 pair of ribs, just like there was 12 thoracic vertebrae. So thoracic vertebrae 1, rib 1, thoracic vertebrae 2, rib 2, and so on down to 12. So often you can tell which vertebrae you're looking at just by seeing if there's a rib attachment there. If there is a rib attachment there, it's got to be the thoracic vertebrae. So when we look at the actual sternum itself, it's divided into sections. Maybe this close up right here like this. Here's an example of this, same as in the picture. You've got this top part here called the manubrium. You've got this middle section here, which is called the body, and then this section right down here, which is called the xiphoid process. That xiphoid process, as you can see down through here, it's getting this blue exterior. Now remember, every time you see blue, it's typically referred to as hyaline cartilage. So that means that your ribs aren't going directly into your sternum. They're actually connected via this hyaline cartilage. So, but even feel your hyaline cartilage now, feel that cartilage there, it feels very solid, right? So feeling down your ribs, that's not bone going straight into bone. Now, why might that be the case? Just even think as we're breathing, that hyaline cartilage adds a little bit of flexibility to allow the actual expansion of your lungs to take place. So we move down, we've got these three sections, and you can actually feel that xiphoid process. If you traced up your ribs and felt right where they're connected, you can almost push in on that xiphoid process, which you're pushing in right there on that part there, and you'll feel there's a little bit of a spring action. So there's the sections. They're actually fused together by the sternal angle and the xiphosternal joint. Okay, essentially they're just the borders between these two fused bones, making the entire bone called the sternum. Now the ribs, whilst I said there's 12 sets, they're actually labelled in 3 different sections. So the first 7 ribs are called true ribs. The 8 through 12 are called false ribs, and 11 and 12, they're called floating ribs. And notice the double up here, so 11 and 12 also captured in the 8 and 12. That means that floating ribs are also part of the false ribs category. So they're a subcategory, if you like, of the false ribs. Now there's a part there in your book where you can sort of follow along. It says true ribs. What's the definition of the true ribs? Now true ribs, by definition, are direct sternal attachment. That's it. We're saying it as few words as possible. It attaches to the sternum directly. Now when we say directly, we're not, we can see there's hyaline cartilage there connecting them. But what we're talking about is this sort of one-to-one relationship. So the rib comes in, it attaches to one bit of sort of cartilage there, and then into the sternum. In. Whereas that's different from the false ribs, which you see down here, which they kind of connect one into the other, and then in. Right? So there's a little bit of a difference going on there. So the true ribs, direct sternal attachment. The false ribs, they're characterized as, or the definition being, indirect sternal attachment. So indirect, so that means it still gets there, it's attaching to the sternum, but via a whole lot of other cartilage all joined together called the costal margin. Right? And again, every time we even hear the word costal, that is a reference to ribs in some way. So you might hear costal mentioned a lot. Anytime you hear costal, we're talking about ribs. And then finally, floating ribs. Floating ribs, by definition, is no sternal attachment. So look at them down here, these bottom 2 sets here, they're not even going to the sternum. They're kind of lying near your abdominal wall. So they're providing some sort of protection at the back, but they're not actually connecting at the front at all. So true, false, and floating. Now also you'll notice, that's the easy part, to be honest, in terms of naming. True, false, floating, pretty kind of easy to get your head around. But you'll notice in brackets next to where it says true, false, and floating, there's a much longer, more complicated name. And that is actually the correct anatomical name given to the true, false, and floating. In other words, true, false, and floating are nicknames, right? Often used out there in society to label, what these ribs are called. So the correct names, the correct anatomical names for the true, false, and floating, you'll see there in brackets next to these in your book, right? The true ribs are called the vertebrosternal. And if you divide that name in half, it's giving you the origin and insertion of where these names are. So vertebrosternal means they go from the vertebrae to the sternum. Vertebrosternal. It's giving you the origin and insertion. Then the false ribs are called the vertebrochondral. And you remember from the lecture, the word chondral, that con sound, it's referring to something involving cartilage. And again, even though they're all attaching by cartilage up here, it's this massive cartilage all joined together. So vertebrochondral is like saying from the vertebrae, cartilage. So that's the false ribs. And then because the floating ribs aren't attaching anywhere anteriorly, they only have an origin, they're often referred to as the vertebral ribs. So vertebrosternal for the direct sternal attachment, vertebrochondral for the indirect sternal attachment, and then just vertebral where they have no sternal attachment. So before we get to any of the questions in your lab book, I feel it's important here to just go through some basic landmarks on a particular vertebrae. right? So you'll notice on all kinds of different pages, you'll see the vertebrae labeled, and there's lots of different things that could be. So we'll go through some of the main ones here, and then we'll use that information to help in future decide which vertebrae is which. So we'll start with this area here. This is just called the body of a vertebrae. Now the body of a vertebrae is this flat section on a vertebrae where the disc sits. So the intervertebral disc sits on this, right? And that's the disc within the body that shock absorb the load as we walk around. This down here is called the vertebral foramen. It's the hole that runs straight through a vertebrae. The word foramen literally means hole. And this is where our spinal cord runs straight down. So, all the vertebrae got this vertebral foramen. Now, on the side here, these are called transverse process, right? Transverse meaning side, process meaning just a lump that's sticking out. So they're called the transverse process, so side lumps, if you like. A number of things happen here, including various ligaments that attach. At the back here, this is called the spine of the vertebrae, so the spinous process. Okay, so spinous process, meaning spine sticking out the back, process meaning back lump, right? These are these. This lump here is if someone bends over, particularly someone that's really skinny, you see all that lumps all the way down the back of down their vertebral column. That's what you're seeing. That's spinous process. Now, we've also got these little smooth surfaces sticking up here like ears. Now, depending on the vertebrae you're looking at, these could change direction, look a little bit different, but these are called the facets or the vertebral facets. And in particular, these ones are on top. They're called the superior vertebral facet. Now, that's a little bit different, but similar to the entire lump, which is the superior vertebral process. Right, so the process being the whole lump, this entire lump sticking up, and then the facet being the smooth part on it. Now that smooth part is part of a joint. So anytime you see a little facet, that means another bone or another facet is going to actually join onto that. So they form little joints. Now I said these are the superior articulating facets, articulating meaning joining or joining facets. We've also got inferior articulating facets there as well. So inferior articulating facets on the bottom of the vertebrae. Now the vertebrae is a great example where there's a lot of facets. On this particular vertebrae, there's actual little facets right there on the side. You can barely see them, and they only appear on our thoracic vertebrae. They're called demifacets. The word demi means small, so little small facets on the side of our vertebrae, and this is where a rib might attach. So on some vertebrae, not on all. A couple of other ones which are harder to see is these flat sections here, either side of the spinous process. They're called the lamina. So that's the lamina of the vertebrae, right? Useful in future. Number one, bony landmark, but also some ligaments attach here. And also this bridge here, right here between the body and everything else. So these bridges, they're called the pedicles. So it's this essentially bit of bone here between this part of the vertebrae here and this front part of the vertebrae here. So they're called our pedicles. When we look at a mess like this, what we're looking at is a whole pile of different vertebrae, and we have to determine which one is which. And once you know what you're looking for, this process becomes a whole lot easier. So we're going to learn how to pick up a vertebrae and go, that is a thoracic vertebrae, or that's a thoracic vertebrae, that's a lumbar vertebrae, that's the first cervical vertebrae called the atlas, and so on. Now there's distinguishing features which help me determine exactly what all of these are. So there's really only 6 you need to learn, and this is the first of the 6. And beyond that, we just put them in size order. There's really distinguishing features between these. So this first one here is called the atlas. This is your first cervical vertebrae. And you know it's the first cervical vertebrae. Well, there's a lot of different ways of doing it, but some of the simplest ways are, it's just this round circle type, almost looks like a monkey face with ears. Another way of saying that is a ring of bones, or there's no vertebral body. So in the other vertebrae that you saw before, just that, we just took one example that had that big flat vertebral body. This one doesn't have it, which means this one doesn't have a vertebral disc that sits around it. It does have these 2 flat parts here, but they were facets. And we had superior and inferior facets of this vertebrae as well. So number one, it was a ring of bones with no body. But number two, as with all cervical vertebrae and only cervical vertebrae, it has these transverse foramen. So we said the vertebral foramen was the big hole down the middle where the vertebrae go. The transverse foramen are these side, transverse meaning side foramen. Transverse foramen means side holes. So you'll find these transverse foramen only in the cervical vertebrae. So this one here is the atlas. C1, the atlas, a ring of bones. That's all you need to really know. And you'll tell that one apart very, very easily from all the others. Now this one here is called the axis. This is our second cervical vertebrae. Now I know it's the axis because it's got this feature sitting up here which is called the dens. So the dens can only be found on the axis, and that's really the main distinguishing feature. There's the only vertebrae out of all of our vertebrae that has this little den sticking up the top. And that's important because the atlas sits on the axis and rotates. So the atlas rotates on its axis and creates a little pivot joint. So when you turn your neck, as in you're saying, no, I don't understand, that's the majority of that movement is taking place between our first and second cervical vertebrae. So where the dens is used to pivot or rotate, or the first cervical, the atlas is rotating around that dens of the axis. So that is C1 and C2, or the atlas and the axis. Now where there's specific names, you have to use them. So if we say what's this, you have to say the atlas, and if we say what's this, you have to say the axis. Now if I look at this one right here, this one here we would characterize as C3 to C6. Now we say C3 to C6 because it's going to be one of them. At this point we're not sure exactly which one it is. We don't have them, you know, the difference between them is just size, but C3 to C6 all have two really distinguishing features. So for starters, they've got the transverse foramen, so they've got the side holes, as all cervical do. But number two, its spinous process, that process is sticking out the back here, it's split into two, and that's called a bifid spinous process. So C3 to C6 have that combination of a transverse foramen and that bifid spinous process. Now, if you were given a number of these that all look the same and you were asked, you know, what's the difference between C3, C4, C5, you would just put them in size order from there. You're never really going to be asked within the categories what's the difference. So if you're given this, your answer would be this is C3 to C6 on its own. If you were given more than one, you'd just put them in size order. So the next vertebra we're going to talk about is our C7, or our vertebra prominens. Now it's called the vertebra prominens because it has this really prominent spinous process. So you notice how this sticks like much further than the earlier ones we've seen out the back. It's very prominent. Now on you, if you trace down the back of your neck and you feel at the very bottom of your neck, there's one sort of a spinous process that's sticking out more than the others. That's what you're feeling, this spinous process of the vertebra prominens. Now, we know that this is the vertebra prominens, C7, as opposed to maybe some later thoracic that don't have that bifid spinous process that we saw earlier, because it still has these transverse foramen. So the seventh cervical vertebrae it's quite easy to spot. It's easy to spot because it's the only one with the unique combination of the transverse foramen, but it's also got this really prominent spinous process that's not split like the other cervical. Now, just to clarify, because it gets a bit confusing, when you look at it from a different angle, like underneath, you'll notice there that the bottom can be quite split. It does divide, but looking at it from the top, you don't see that bifid spinous process at all. Now we're going to move down here into the thoracic vertebrae. This one's around our mid-thoracic vertebrae. And you notice a couple of different features of a thoracic vertebrae compared to what we saw in the cervical. For starters, we see a body here which is characterized, they call it heart-shaped. And you'll notice it's the body, this is where the disc sits, is in that heart shape. You'll also notice that the spinous process is all of a sudden very steep and sharp, and it can begin quite shallow and get steeper and then shallow back out again. But one thing you'll notice with all of these thoracic vertebrae is that this spinous process is quite pointy. Another way, and an important way, is to look at the facets. So these superior articulating facets, they're pointing, in this case, towards the back. So the smooth surface is kind of pointing straight back this way towards where I'm sitting. And the ones on the bottom would be the opposite. They'd be pointing, as you can see under there, straight forward. So you could call this a number of different things when we talk about the orientation of the facets. One way to do it is to say they face anterior and posterior. But an easy way to do it is to talk about the planes that they are in. So this would be described as in the coronal or frontal plane. In other words, they're across the body, dividing the body into anterior and posterior for the most part. And the reason we do that is because that helps us determine the movement that occurs predominantly at these areas of the vertebral column. So if I say these are in that frontal plane, they allow frontal-based movements. That means when I take one and I put it on top of the other, then they are able to move on each other in that way. And that way, for a vertebrae, in this example, would be lateral flexion. So when we laterally flex our spine, a lot of that is happening at the thoracic region, and it's got to do with the shape and the angle of these facets that are both superior and also inferior. Now, as we travel down the vertebral column, we see here, this is a lumbar vertebrae. Now, lumbar vertebrae, for starters, we see different shape of the body. It's more called like a kidney bean shape, right? So it's less heart-shaped, it's a little bit more rounded, right? And we notice again, it's getting bigger. The lower we get bigger. I'll explain that in a moment. So the shape of the body is kidney bean shape. We look at the spinous process. It's a lot more trajectorying straight back, so posterior, and it's quite blunt when we compared it to the sharpness or the pointiness of our thoracic vertebrae. So the spinous process is quite blunt and protruding posteriorly. And when we look at the facets, look at the differences going on here. We saw in the vertebrae here in the thoracic, they were pointing sort of very flat straight back. But in the lumbar, those facets there on the inside pointing towards each other. So right there and right there, pointing towards each other at the top, superior. And if I looked at the bottom, they're here on the outside pointing outside. So you could say they're pointing medially and on the bottom pointing laterally. Another way to say this is they're in the sagittal plane. So remember, the sagittal plane divides the body into right and left parts. So that is in line with that plane. This is important because when we talk about movements at the lumbar vertebrae, there's a lot of flexion and extension that occur here, so sagittal type movements. So knowledge of that facet orientation, so in this case saying the orientation of the facets in the lumbar vertebrae is in the sagittal plane, that helps us determine what movements predominantly occur at this region of the vertebrae. So in the lumbar's case, it would be flexion and extension because they're in the sagittal plane. So we talked about all these. I'll take just an example here of 3. So here we've got an example of a cervical 3C to 36. Here's a mid thoracic and here's a mid lumbar. And notice the size of these continues to get bigger. Right from the top, right down to the bottom, they continue to get bigger. This is a classic example, and you would have heard in the lecture, of Wolff's law. So Wolff's law is a law which describes a bone responds to the stress placed upon it. Now the stress in this example is just load. So the load of the body above it. So the load, it takes more load lower than it does higher because there's more weight down on it from the upper part of the body, which means the bone responds by getting bigger. So you'll notice if you lined all your vertebrae up, they would get from bigger the further down you go. Which means when I come to something like this, this is my very, very last lumbar vertebrae. My last lumbar vertebrae, it's starting to really flatten out. It's a lot flatter and bigger, and you can even see it's a very short spinous process. And I've brought this one into play particularly to help describe what the sacrum and the coccyx looks like. So the sacrum and coccyx, I'll bring them in here, looks like this. I'll bring back that lumbar vertebrae in a moment. And you'll notice here, this just looks like a whole mess of bones. There's all kinds of things going on here. Remember, the sacrum had 5 fused vertebrae, and the coccyx here have 4 fused vertebrae. Now at this point they're not even looking like vertebrae. But a lot of these features that we see in here can be described using the actual vertebrae's features. So it kind of looks like this. So if this is my last lumbar vertebrae, so this is L5, and I've placed it on top of my sacrum, and it fits like that. So the features on the sacrum, and you can see the labeling, you got this crest down here called the medial sacral crest. And there's spaces provided where it's sort of saying, well, why does that medial sacral crest occur? Now, rather than saying why it's occurring, it's more so just trying to show you that they are there, they're remnants of what is occurring up here in the vertebrae. So up here, we've got spinous process sticking out the back, and here we're calling this the medial sacral crest. So all that really is fused together spinous process. We had the vertebral foramen up here in the lumbar vertebrae, and here, now this is a plastic model so you can't see a canal, but there's a sacral canal that runs straight down through here. The sacral canal, all that is just fused together vertebral foramen. Now, we've got the lateral sacral crest on the sacrum here. All that is if you look at what's sticking out the side of a lumbar vertebrae here, this is our transverse process sticking out the side. If we were to fuse together all these transverse processes, all it would do is just create a crest down the outside. And in this case, we're calling it the lateral sacral crest. Now, the only other little tricky one here is all these little holes. Remember, holes are called foramen. These are called the sacral foramina. It's many small holes. Now, we talked about before with the vertebral foramen having the spinal cord running through it, pretty much every foramen has blood vessels or nerves running through it. So at this part of the vertebrae, we have blood vessels and nerves coming out through all these foramina and running down your legs. So there's a lot of nerve action going on down here, popping out through all these holes. So quite simply, if you were to fuse together, like if my finger here represents the fusing of the transverse process into the lateral sacral crest, it's just got to leave that little hole. So why is it there? It's just leftover remnants from when you fuse together the transverse process, but more importantly, it's where the nerves and blood vessels run through and travel down to the lower parts of your body. So that concludes the lesson on the axial skeleton. So let's just go through some of the key features that we have to know here. So for starters, how many were, in each section of the curve and the way that the curves flow, how to, remember how many are in each one. We had to remember how the actual curves are developed through birth up through infancy and why. We also want to know about those abnormal curves, so what they're each called and how to define them and what they might look like. Then we've got the bony thorax, so the region of the sternum, each of those regions, the ribs, what they're all called, how to distinguish one from the other. And then you get down to that vertebrae, so labeling a vertebrae, and you'll notice that if you looked in all the pictures of the vertebrae, sometimes there's a lot more in terms of labeling. Don't worry about the ones we haven't taught you, just follow the ones that we've taught you in the lesson. They're the ones that we really have to know. And then between now and next week, what you really want to do is know what each vertebrae looks like. So we should be able to put a vertebrae, and we're going to do that in some sessions, put a vertebrae in front of you and say, what's that? What's this? What's that? What's this? And if you know what they're looking for and you know what you're looking for, you should not only know what it is, but also how you're arriving at that. Yes, I know it's that. It's got a spinous process in this angle. It's got facets in this angle. It moves in this direction. So all those different features of each of the vertebrae.